What's your fit, Jerry?
Hello everyone, and welcome to the 2013 Your Natural Baby Fair. This is a special discussion that we have going on, and we are broadcasting live from San Diego, California. I'm Sunny Galt, and with New Mommy Media, we produce 3 different online shows, or audio podcasts, if you will. One focuses on pregnancy, one focuses on parents with newborns, infants, and toddlers, and another one focuses on breastfeeding. And I'm the host of our show that focuses on pregnancy called Preggy Pals. I'm actually pregnant again. I don't know if I told you all.
No.
Yeah, you just found out a few weeks ago. Hello. We've already made the announcement, so this is not a brand new thing to people that already know me. But so I'm excited to talk about our topic today about childbirth options. It's really important. A quick, announcement that I wanted to make. We want you guys to participate in our conversation. So as we're chatting, if you want to, if you're on the video page, if you just scroll down a little bit, there's a chat box. Feel free to add your comments, or if you have questions as we're talking about stuff. We really want these discussions to be as organic as possible, and we want you to feel like you're right here with us, like around our little table. You're on this side chatting with us. So feel free to just chat away, list your questions, and we'll incorporate it into the show if we see someone raising some issues that we should be talking about. The other thing is, if you guys are on Twitter, if you use the hashtag YNBF2013, that stands for Your Natural Baby Fair 2013, we're going to be looking for that as well. So that's another way you can participate in the conversation. So again, we're talking about childbirth options, and this is important because we have a whole panel here at the fair later on today that's going to be focusing on this. And Jerry Ryan is joining me, and as well as Nicole Morales, and they're both experts on this panel. And then Erin Esteves is joining us at the end. From the parent's point of view, I think Erin and I are both going to be giving a parent's point of view on some of these options. So I think the bulk of what we're going to talk about today focuses on like VBACs, breech babies, and maybe thinking a little bit outside the box, so if you're going for a little bit different style birth, what some of your options are. So I'm just going to throw some stuff out there, ladies, and you guys can answer just as something strikes you. Why should we look at birth as an option? I know it seems like a simple question, but I feel like so many times we're kind of pushed in certain directions, but we do have options here.
We absolutely have options. I like to look at birth as options, just like you go into a restaurant and you sit down and you look at the menu and you get to choose what you want to order.
Right.
Why would we not look at birth? It is a life-changing event in a woman's life. Why would we not look at that as options? It doesn't mean that everything will go as you plan, but if you don't know what the options are, the reality is you have no option.
Right.
So it's really important for parents to be to find out what the options are. Are there different choices that I can make that will have a difference in the way I feel about the birth, I feel about myself, and maybe even in the way I parent?
Do we have more options available now than, let's say, like 5 years ago, or is it more just that we're empowering people to learn about those options?
I think just that there's the access to the internet and the access to information is so very different than just 5 years ago. Even though we had the internet 5 years ago, we didn't have as much information up there. So at this point, you can look at what your range of options are. I mean, anything from an assisted birth to the other extreme, which would be probably the choice of a planned cesarean that was unnecessary. And that, of course, is debatable as well, by other people, whether it be unnecessary or not. But, you have a large range. So our options are we're more able to go out there and research it and look for really what we want. And then, of course, you have different people telling you what you should want.
Right.
I think the other side of that, too, just to add along to what she's saying, is we've had some very visual, well-known individuals that have come forward and laid out some options in birth. And I think that voice of somebody who's easily recognizable has given the mass public the opportunity to explore that birth is not just something that, once you're pregnant, you sign up for whatever is going to be given you. You have choices in whatever setting you choose to birth, in whomever your care provider is. And so I think that putting of information out there was so important that it now has people thinking about it and researching it.
Right. I would imagine, too, one of the things is, we put all this information out there, and sometimes you get information overload. And it's like trying to go, options are good, but I think sometimes as parents we're like, well, I don't know, should I do that? And it becomes, kind of this fact-finding mission and, just trying to figure out kind of what works for you. But I'm glad we have the options, right? So one of the things that I wanted to do is go through some of these kind of hot button terms and talk about what some of the options are that women have that they may not even know about. So the big thing that I hear about a lot, on Preggy Pals when we talk to various people is, well, I had a C-section or whatever after they determined there was a failure to progress. So what is a failure to progress as that term that they tell us in the hospital or whatever?
That daunting.
Yeah, right. Who wants to take that tough one?
So do you want to know the clinical definition of that?
Well, let's do both. Let's talk about what it's supposed to mean and then what it's treated as.
Okay, how about I'll talk about what the clinical indication is.
Right.
Basically, if we look at birth as a process and we take a whole lot of women and we put them all together into a big basket and then we average the time that a first-time mom takes to birth versus the time that it takes a subsequent birthing mom, so second, third, fourth, whatever baby, to birth, we put all those averages together, and this averaging was done back in I believe it's the 1950s, and we put that all together, then we come up with a mean time of what we would expect a birth to look like. So, interestingly, the study was done in an institutional setting, in a hospital, where we have lots of things that we can add to make the birth go faster, including medication and other things. So when that particular study was done, what came off of that, they developed what's called the Friedman's curve, named after Dr. Friedman. And the idea was that we would expect in a first-time mom to have progress after she's in good active labor, so after 4 to 5 centimeters, we would expect her to progress about 1 centimeter every hour or 2. 2 hours being the outside limit. With women who've already had a baby, then we would expect it to be a little bit faster. So if we plot everyone on this curve and somebody falls outside of that, then that could be termed failure to progress.
Okay.
So the reality, though, is what about all the women who went much faster? Right. And what about all the women who went much longer to reach this mean average?
It's like we're cutting them off. Right.
Correct. So we're not giving birth the opportunity, or this baby the opportunity, to have the length of time that it would normally have without a lot of intervention. So, and I'm not suggesting that there is no such happening as a failure to progress. Sometimes we do have that, but I would also offer up that sometimes it's failure to wait.
I know that if I can just jump in, I know that in my instance, you mentioned the 4 centimeter mark. I never reached that mark. I got to 2 centimeters, and they, 4 or 5 hours later, they're like, oh, well,
Really?
Yeah, so I think back and I'm a little disappointed, but then the medication kicked in, so.
Then you're in another place for a while.
Well, I wanted to add to what Jerry was talking about that average. And the problem is that was an average. That was data collection. And what it wasn't is it got redefined as being normal, not average.
Right.
And so then it became, instead of let's have people being average, let's have them being normal. But what we didn't think, there's nothing you can do about those ladies who have babies in the car or in the elevator or before they're expected to have babies. But with the ladies on the outside graph going off the chart, we're also looking at, well, what is normal about their labor? Because they're being usually denied food and drink within these studies. And how is their body going to work? They're running this internal marathon without any reserves, without being given anything. They need to be eating. They need to be drinking water. They having electrolytes. And all of that helps with the longer labors anyway.
Right.
That might move them right into that average.
Right.
If they were allowed.
Right.
To eat.
And to tag on to that also, many of them are also relegated to the bed. So they're not really able to get up and move around as they would in a normal process. So especially very early in labor, we expect women are going to be up and moving and eating and drinking. And there comes a point in labor where moms want to begin to nest. Usually at that point, they're not wanting to eat a lot. Either the digestive process slows down, but all of these things happen naturally over a period of that labor. And then we also think about the baby. So babies are a very active part of labor. They move through the body with mom, or sometimes in spite of mom, because mom is stuck in very recumbent positions.
Right.
And a lot of times there's this quote-unquote failure to wait or progress, however you want to put it, because the baby's not in the optimal position. So part of the work of labor, especially, let's say you're at 2-3 centimeters and you're having this intense contractions and there's not a lot moving forward according to the medical standards, a lot of that is baby shifting to a different position and wanting to get into a different position. So at that point, that's also the point where you say, wow, how can we help that happen? So gravity, movement, changing positions, those are things that should be on our radar when that's happening, because those are things that, all right, well, things are slowing down for a reason, and we can always see that sometimes as a blessing. We seem to, a lot of times within childbirth, people see it as this train, and you get on this train and you start going, and if it's not going anywhere, then of course you keep moving.
Right.
And if it's not working, then you have Pitocin or a cesarean birth.
Right.
Rather than saying, stop, let's just get off this train for a minute and kind of get a perspective from up above about what's going on. And some of that would be, wow, how can we possibly move this baby into a better place?
I'm glad you said the word train, because for me it felt like a train was going by.
Yes.
It really did. I felt like the giant cavern and a train was barreling through. So when I got to that point and they said, you're not progressing,
Your panel's done.
I was so overcome that I couldn't detach myself. I couldn't step back and take a look at things and say, okay, let's slow this down and let's just wait a little bit longer. So I think that also has to be taken into consideration, that overwhelming sense of desperation, I guess, or just helplessness. The wave had taken me away. I was gone.
Right.
And all of that produces catecholamines, which interfere with oxytocin, which can affect what is seen as the progress of labor.
And I'm going to tell a story because I think we learn a lot by storytelling. And I had a client, as a doula, I had a client one time who, it was very important for her to not have a cesarean. She was an attorney and she needed to be back to work in 6 weeks, and her biggest goal was not to have a cesarean. And she also wanted her epidural. So we discussed, well, when would be optimal to do that? And so she was induced. We were at the hospital, 12 hours, Pitocin, continued to increase it. She was having very mild contractions and in very similar dilation to you, so like 2 centimeters. And at the end of 12 hours, she had made no change whatsoever. And so I floated the idea of, well, if you haven't changed at all in 12 hours, why don't you discuss with your physician and see, how she feels that the baby's doing, how you're doing, and is this something that you really have to do right now? What if you went home and came back in 2 or 3 days? Is that a possibility? And it was interesting because she had a huge breakdown. She sat and cried, and it's like, I never imagined I would walk in a hospital and not walk out without my baby. And her physician came in and they had the discussion, and her physician was fabulous, and she just said, you haven't made any progress in 12 hours. We can continue this for 12 hours, and you probably won't make any progress either. So since your goal is to not have a cesarean, you're healthy, your baby's healthy, why don't you go home and we'll set this up for later in the week. Interestingly, 3 days later, her water broke on its own. They went to the hospital. They did need to augment, so they got her on Pitocin again. The family called me. I got to be there with them for that. She left with a baby then. But sometimes also it's the mindset of the family.
Oh, absolutely. Absolutely. I think my husband, he was so distressed at seeing me in pain that he was just like, okay, this doula thing isn't working. Give her medication and let's get this over with. So, unfortunately, even though we had gone through all of the classes and done all of the research and got a doula, and the fear was and the stress was just so overwhelming for us. It was hard.
Well, and for those of you guys who are watching us now broadcast live, I want to introduce you to Dr. Kapatanakis, who is on the end here, this handsome man at the end of our table. And he's an OBGYN right here in San Diego. And we were just talking about failure to progress, Dr. Cap. But I want to kind of change gears. I want to talk a little bit about VBACs and some of the hurdles that women are going through when they try to have a VBAC. And I'd love to kind of have everyone's perspective on where they deliver and how that impacts your choice to have a VBAC. I mean, what is the situation nowadays, Dr. Cap, with needing to deliver or wanting to deliver at a hospital but still wanting to have that VBAC option?
Sure. I mean, the current recommendations from the American College of OBGYN is that in order to deliver out of a hospital, you need 24-hour anesthesia and you need 24-hour OBGYN coverage. So that becomes a little bit technically difficult for some of the smaller hospitals to have a full-time anesthesiologist in-house. Becomes a little bit technically difficult for smaller hospitals to have an OBGYN in-house.
Right.
Because if you needed to do, unfortunately we sometimes have to do emergency C-sections, you need to, be able to do that in a timely fashion. Getting 2 doctors in from home, preparing everything takes a little bit longer time. So that's one of the biggest setbacks with, having to have a VBAC in the hospital.
Okay.
The other requirement, at least at Scripps or Scripps Encinitas, is that you need at least a HepLock IV, and then you also need to have continuous monitoring. Okay. The concern is that incision, although the risk is less than 1%, can open up, and which is called a uterine rupture, and that would be the biggest concern. I'm at Scripps Encinitas. I deliver basically all my own patients so that I have that 24-hour coverage, and there's 24 anesthesiologists, so I have plenty of VBACs that do come to me, and I think the biggest success rate that I see is, one, don't intervene, let mamas go on their own, and the second thing is having mamas get extra support. I think doulas are an excellent way to provide that support to moms so that they understand, that this is a naturally occurring process, and to believe in their bodies, and just to give it time so that the body can do what the body's going to do. Now, when you look statistically at indications for C-sections, and then you look at trial of labor after C-sections, there are some good indicators that your success rate is probably going to be higher than others. Breech is a perfect example. When a baby's breech and you have a C-section, your chance for success with VBAC should be the same as if you had never had that surgery, in theory. The indicator for your first C-section being, I got fully dilated, I pushed for 3 or 4 hours, baby didn't come down, unfortunately probably has one of the lower success rates. And I don't want to say it's the pelvis or position. I can't even comment on what may have happened with your first, because, I've had plenty of patients that I've labored where that situation occurred and we needed to do a C-section after pushing for 3 hours that have come back to me and had successful unmedicated VBAC. So, it's kind of hard to say what exactly that is. I never like putting labels. I never like telling mamas the pelvis is too narrow or the baby's too... I don't know what happens. I don't know why things don't work as well as they do. But I know when I don't intervene, I have the best success rate.
Yeah.
And it's just doing a hands-off kind of approach, unless you need to step in.
For sure. Go ahead.
And I would like to just talk for a minute about the emotional aspect, because I think women who are attempting a VBAC have a huge emotional aspect that they have to deal with. They've been through the cesarean door, whether it was an emergency or just failure to progress or whatever the cause was. So they know what that door is. They really work hard to avoid that, but there's a lot of milestones along the way that they're having to deal with. Maybe getting to the dilation, which they stopped at last time. No one can guarantee they're going to have a VBAC until the baby is out.
Right.
And then, okay, wow, that was a great success.
Yeah.
So they have to go in mentally set that they want this vaginal birth, they're willing to work for it, but they still may end up with a cesarean. And so that oftentimes can be a very emotional thing as to at what point am I willing to throw in the towel? At what point do I feel more comfortable through the door I've already been? And no one can make those decisions except for the woman herself. So I think she really needs to have that full range of options. She can attempt the VBAC, she can work for it, but the reality is, like Dr. Cap said, there's many other confounding factors that no one knows until the birth is finished.
Right. I want to talk briefly about breech babies and what some options are. Nicole, I'd really like you to address this. I know you've gone to various seminars and stuff that talk about breech babies. So if your baby is breech, a lot of women are just like, it's got to turn, we've got to do something, or it's going to be a C-section. So what do you have to say to those mamas out there? What options do they have?
Well, I think that there's a lot of different options that happen even before you get to the birth itself. So, and even addressing some of the things that that he was talking about VBAC, you know, part of it is also looking at, all right, what's going on inside the uterus so that the baby is breech, especially once you get towards like 33, 34 weeks. A lot of babies are breech earlier on. That's just that's very normal. And it's about what's going on inside there. So, you know, we're seeing more breech babies, we're seeing more posterior babies, and it's a lot of it has to do with the architecture of our society. So, you know, different things could have happened with mom's pelvis. She could have had a sports injury. She could just be sitting in her car in the bucket seats that you have,
Really
which are not
interesting,
designed for pregnancy. And they could also be sitting at a computer, slightly twisted. And
Right.
so sometimes the reasons for breech presentation have to do with tightened ligaments. It has to do with different imbalances and with how the uterus is positioned. So I think the first thing to start is how can we do some prevention? How can we say, oh yeah, let's try to loosen up those ligaments earlier on, closer to 33 weeks, and have them start doing a lot of this things on the Spinning Babies website. If you go to the Spinning Babies, you can just start clicking away on pregnancy and breech and get a lot of really wonderful information about how things that you can actively do. And I would really suggest it for VBAC as well. For women who are looking for a vaginal birth after cesarean, how are we going to set up things optimally in your body and how everything's connected with stretching or how you walk or where you sit during your day when you're in traffic or watching movies and really change those. So that's the first aspect, I think, of looking at breech presentation is that you have those choices earlier on to change.
Okay.
And as baby gets bigger, that becomes a little bit more difficult.
Right.
So the choices then become, sometimes the choices seem a lot more limited and seems more like a lack of choice. But you also have choices like going ahead and doing an external version with a doctor in a hospital, and they can help turn baby. There's different exercises you can do with ironing boards upside down and lying backwards and helping bring the baby out of the pelvis and then following the baby around with frozen vegetables. And there's lots of different things you can do to work on turning baby, including having a nice, firm parenting talk. But as you get further along, you know, then you're starting to look at, wow, if my baby's still breech, what are you going to do?
Yeah.
So there seems to be a lack of options in a hospital, but there are options out there. Sometimes you have to change providers. Sometimes you have to travel. But you know, wherever you're planning to deliver, there are options. You've just got to really search for them, and that might include having a vaginal birth, might include having a planned cesarean birth, or even going into labor and then going in for a planned cesarean birth. I mean, there's always a slight chance that babies can turn to the point of delivery, even in labor. It's been shown that babies could turn. It's not that common, but it does happen. But also, going into labor is good. It's good for the uterus and the baby, and getting different hormones flowing, and it's better. It has better results for the uterus for subsequent pregnancies. So those are all different options, and vaginal birth seems like the one that's hardest to find, but it's out there, and studies show that it's just as safe as cesarean birth. It's with a skilled attendant.
Right. Well, the one thing that I wanted to mention as we conclude is that we actually had Dr. Kapitanakis on Preggy Pals. This seemed like forever ago. It was one of the first episodes we did to talk about natural cesareans. I'm in the category of needing cesareans for every baby. I'm pregnant again. I didn't tell you, Dr. Kapitanakis. I told everyone else before you got here. So baby 3 is on the way, December sometime, so it's a ways away. But, you know, I had a complication my first birth. and they basically said, listen, you're really putting yourself at risk if you try to deliver vaginally. And so for me, it's been a very hard road because I wanted to do a vaginal birth. And my second baby was cesarean. And as I was saying, Dr. Kapp was on our show to talk about a natural cesarean, which doesn't mean it's unmedicated. I don't want to give that, you don't want to be cut open without something to help you out. But anyways, that's an option. So there's a lot that's involved, and we did a whole episode on it. So I just wanted to briefly mention that because for people that know they have to have cesareans, it still is another option out there that makes you feel closer to the baby and helps with that bond. So I just want to mention that really. But anyway, so we're out of time. I got to wrap it up. A couple things I want to say at the end, just to thank you guys for all being here. And they're all going to be here talking at the fair. They have a whole panel that's focusing on this very issue. So we're so glad to have you guys on our live show. Also for our shows, Preggy Pals, Parent Savers, and the Boo Group, if you guys are watching us live online, you can save 50% on all of our club memberships. All you have to do is go to any of those websites and visit the members section and enter a promo code, which is YNBF 2013, which stands for Your Natural Baby Fair 2013. And just enter that promo code and you'll get 50% off all of our memberships. So we're going to take a quick break. When we come back, we're going to be talking about attachment parenting with Linda Folden Palmer. So thanks so much for watching and stay tuned.